Today, we're reporting a new case of novel coronavirus in Santa Clara County. This is the third case to be identified in our county, but it's different from our other two cases in an important way. Like the California case reported 2 days ago, our third case did not recently travel overseas or have any known contact with a recent traveler or an infected person.
That was a health officer in Santa Clara County, California today, announcing what is the second known case of a person being diagnosed with coronavirus in this country without there being a clear indication of where that person got it. The first one was 2 days ago in Solano County, California. The second one was Santa Clara County today. And now tonight, since we have been on the air, there appears to be a third case. Oregon health officials announcing within the last 20 minutes that there is a third case that appears to be what they're calling a community transmission case. Somebody who has been diagnosed with the virus, where the route by which that person got infected is not yet known, and it is now being traced by public health officials. Joining us once again is Donald McNeil, who is a science and health reporter at the New York Times. Mr. McNeil, I wanted to ask you about the first community transmission case, one of these cases where they don't know what it came from, was the Solano County. Nurses Union put out a statement about that tonight, raising the alarm about basically health resources as the number of cases in the United States starts to rise, saying the recent UC Davis Medical Center COVID-19 case highlights the vulnerability of the nation's hospitals to this virus and the insufficiency of current CDC guidelines. The single patient admitted to the facility on February 19th has now led to the self-quarantine at home of at least 36 RNs and 88 other healthcare workers. These 124 nurses and healthcare workers are needed now more than ever, but they have instead been sidelined. Lack of preparedness will create an unsustainable national healthcare staffing crisis. Wanted to get your reaction to that.
That's a lot of people to lose in your hospital.
Yeah.
You can't keep taking in new patients if you keep having to quarantine all the doctors and nurses. I mean, eventually, unfortunately, that will have to stop, because they're going to need people who are not sick, who are not actively sick and actively shedding virus to work, because you can't. One case like the Solano case or the UC Davis case, it doesn't worry me so much. What will worry me is when an emergency room that normally has 10 cases of pneumonia a week suddenly has 40 cases of pneumonia that week. And, you know, and that will happen eventually. But these sort of individual cases that are not known to a change of transition has actually been going on in Japan for a few weeks now. So we've got a little more time before we are where Japan was, but unfortunately, eventually, there will be, we'll be where Iran was. There'll be large numbers of unexplained cases. We'll have a lot of them, and then eventually we'll be where Iran was, and 1/3 of Congress will get it probably. They'll have to close down a lot of things, including our parliament. It's a public meeting.
But if in individual cases we do have one patient and more than 120 healthcare workers self-quarantined and not coming to work because of it, clearly that ratio is unsustainable even for a week.
It's an abundance of caution kind of move.
Yeah.
Eventually they're going to have to ask all those people to come back to work and say, look, we're just going to have to take it. Ultimately, in epidemics of respiratory disease, you start assuming that most people are going to have mild cases. You know there's transmission in the community, and you're going to have to ask people, you have to treat people who are really sick and hope that the mild ones can continue. And unfortunately, the real sick ones are the ones who are going to end up with pneumonia and going to need to be on ventilators or on oxygen.
In terms of the potential scale of this, just inside the United States, and healthcare resources that we have available, hospital beds, intensive care beds, ventilators, trained healthcare staff, how do our resources match up with the potential scale here?
I have not looked into these figures myself, but if one of my colleagues was doing some research on this yesterday, and he said that the pandemic preparedness planning for the United States for the worst possible case of this kind of epidemic respiratory would need 750,000 ventilators in this country. We have about 75,000, he said, so about 10% of what we might need. I mean, a ventilator is a $25,000 to $50,000 device. It's like having a car, and you can't just run out and buy one in the showroom. It's not something you stockpile. You have to order them. And, I talked to a hospital director yesterday, and he said, we have some extras in storage in Brooklyn. And I thought, okay, that's great. But if the number of people who have on ventilators triples, quadruples, quintuples, in China, they built 2 hospitals in 10 days. a 1,000-bed hospital, a 1,600-bed hospital. They got 25,000 doctors and nurses to march into Wuhan, knowing that they were risking their lives, and start treating patients. I mean, the whole of China focused on Wuhan. Outbreaks of flu in this country tend to start in one place. This year started in Louisiana and then spread out from there to the country. A couple of years ago, it started up in Maine or the Northeast. It would be a good thing if this country were mobile enough to be able to send a lot of doctors and nurses to the epicenter of the outbreak, but we're not a mobile society. I mean, we're mobile, but people have jobs and they have obligations to their own hospitals. We're not organized from the top down the way China is. So we may have some troubles responding to this in the same kind of people's war way that China did to their outbreak.
Especially if we're not testing widely to identify where it is.
That's a big scandal. The fact that we are not testing as much as Italy is. I mean, we made test kits as soon as we knew the sequence of the virus, but the test kits turned out to have a problem. They turned out to have at least one of the reagents was bad. So a minority of the states in the country now have test kits, state and localities. The WHO is having theirs made in Germany. I don't know why we're not asking the WHO for copies of theirs and distributing thousands of those around the country. We should be testing lots more people who have pneumonia, have undiagnosed pneumonia. We should not just be testing people with travel histories to China or travel histories to India or travel histories to Iran or something like that. I meant Italy rather than India. We should be testing people who have pneumonia if we know it's not flu and we know it's not, if we haven't isolated the bacteria and it's not responding to antibiotics. We should be testing them for this.
Donald McNeil, science and health reporter at the New York Times. Thank you for being here from this very alarming story. Thanks. Appreciate it.